The pancreas is responsible for making insulin and glucagon, both of which work to maintain blood glucose levels. Insulin is made by the beta cells of the pancreas. When blood sugar levels become elevated, insulin is released from the beta cells. This helps restore normal glucose levels by moving insulin into cells and allowing insulin to bind to insulin receptors on the cell membrane. A fasting glucose level of 70 to 110 milligrams per deciliter is considered normal. As soon as insulin binds to its receptors, a series of reactions take place, making it easier for glucose to pass into the cell. Diabetes mellitus is a common chronic endocrine condition in which the lack of insulin or poor function of insulin impairs glucose metabolism, leading to problems in fat metabolism and protein metabolism that can affect the function of every body system. Without the ability to regulate glucose, many acute and chronic health problems occur, increasing the patient's risk of early death. Glucose is a simple sugar important for energy production in cells and organs. Glucose is also a part of many carbohydrates. Insulin is a hormone produced by the area of the pancreas known as the islets of Langerhans and works to regulate the amount of glucose in the blood. Like other hormones, insulin is a key that binds to its cellular receptors, which act as locks. When insulin binds to its receptors, doors on cell membranes open, allowing glucose to enter cells, which lowers the blood glucose level. Glucose in the cells is metabolized to generate the cellular energy needed to maintain maximum cellular and organ function. When blood glucose levels are lower than normal, hypoglycemia, cells and organs cannot metabolize it to provide energy, and cellular function can be greatly reduced. However, too much blood glucose, known as hyperglycemia, leads to severe complications over time, including cardiovascular disease, peripheral nerve damage known as neuropathy, kidney failure, and damage to the blood vessels and the retina. Diabetic neuropathy that causes blindness. Good glucose control, sometimes called glycemic control, requires balancing blood glucose so that levels are constantly in the normal range. List the desired laboratory values that indicate good blood glucose control for the two most common tests, fasting blood glucose levels and hemoglobin A1C. A fasting arterial blood glucose lab value would be between the range of 70 to 110 milligrams per deciliter. A capillary blood glucose, when testing a patient's blood sugar, would be between 70 and 110, but definitely nothing less than 70. For a hemoglobin A1C, ideally we like to see our patients between 4 and 6%. Insulin is called the hormone of plenty because its release is triggered by hyperglycemia. Insulin allows cells to take up, use, and store carbohydrates, fat, and protein. Many body cells have membranes that do not allow glucose to move into the cells to participate in metabolism. When insulin binds membrane insulin receptors, the membranes become more open to glucose, allowing it to enter. The insulin allows cells to take up, use, and store carbohydrates, fats, and protein. This helps to prevent hyperglycemia. In addition to insulin and glucagon, other organs and hormones help maintain normal blood glucose levels by balancing glucose uptake by cells and glucose production by the liver. Blood glucose levels after a meal are controlled by the emptying rate of the stomach and delivery of nutrients to the small intestine, where they are absorbed into circulation. Endocrine hormones, secreted in response to the presence of food in the stomach, work with insulin to prevent blood glucose levels from becoming too high after meals. The actions of incretins increase insulin secretion, inhibiting or stopping the glucagon secretion, and slow the rate of gastric emptying. All of these actions help to prevent high glucose levels. The brain and other parts of the nervous system require a continuous supply of glucose from the blood because they cannot store it. Other organs can use fats as well as glucose to generate energy in the liver and muscles. Glucose is stored as glycogen. Fats are stored as triglycerides in fat cells. During a prolonged fast or after illness, proteins are broken down and some of their amino acids are converted into glucose. Insulin keeps blood glucose levels from becoming too high, helps maintain blood lipid levels in the normal range, and prevents muscle protein breakdown. Recall that in diabetes mellitus, the lack of insulin or poor function of insulin impairs glucose metabolism. When glucose metabolism is poor, problems in fat metabolism and protein metabolism also occur. When there is not enough insulin, or when insulin does not bind well to its receptors, glucose does not enter cells and instead circulates unused and at high levels in the blood. For this reason, the main feature of diabetes mellitus is chronic hyperglycemia. About 29 million people in the United States and 2 million people in Canada are living with diabetes mellitus. Almost 1/3 of people with diabetes have not been diagnosed and are not being treated. Another 90 million have pre-diabetes, which is abnormal glucose metabolism that carries a high risk for developing into actual diabetes mellitus. Diabetes mellitus that is not well controlled can reduce the function of all organs and tissues. The most serious complications of uncontrolled or poorly controlled diabetes mellitus are hypertension, high blood lipid levels, early onset of cardiovascular disease, kidney failure, stroke, and blindness. The complications of diabetes mellitus can be delayed or reduced by maintaining good glycemic control and keeping blood pressure and blood cholesterol levels as close to normal as possible. The classic symptoms of diabetes are polydipsia, increased fluid intake, polyuria, excessive urination, polyphagia, hunger with excessive eating. The person with untreated diabetes remains in a condition of metabolic starvation until insulin is available to move glucose into the cells. If insulin is not produced by the pancreas, or there is a problem with the insulin binding to its receptor, cells cannot use glucose for energy. To make up for this problem, the body breaks down fat and protein in an attempt to provide energy and increase the production of glucose from other sources. Muscle and protein is reduced, and the body also moves fatty acids into the blood to use instead of glucose for cellular energy. When this stored fat is used for energy, ketone acids are formed and collect in the blood, resulting in a dangerous and potentially fatal condition known as ketone acidosis. Glycogen is a stored form of human carbohydrate. Euglycemia means a blood sugar level with the normal range. Hypoglycemia is a lower than normal blood sugar level, which means a blood sugar level that is below 70, regardless if it's a capillary blood sugar check with an Accu-Check machine or if it is a fasting arterial blood sugar. Classification of diabetes mellitus. In addition to the diabetes that can occur with pregnancy, gestational diabetes, there are two main types of diabetes mellitus. Type 1 diabetes mellitus is an autoimmune disorder in which the beta cells of the pancreas that store and release insulin are destroyed. When this occurs, the immune system takes destructive actions and produces antibodies against them. This can occur as a result of a genetic predisposition or as a response to infection by certain viruses such as a rotavirus or a coccidiovirus. A DM type 1 is often diagnosed in childhood and sometimes even before the child is 1 year of age. Other names for diabetes mellitus type 1 are insulin-dependent diabetes mellitus, also known as IDDM, and or juvenile diabetes. With DM type 1, the pancreas produces no insulin. The patient must take insulin daily for life unless a pancreas transplant is received. For diabetes mellitus type 2, known as DM type 2, is a disorder in which the person continues to make some insulin, but it does not bind well to its receptors, and therefore is a reduced response of the body to insulin, called insulin resistance. Eventually, the pancreas makes less and less insulin. The insulin resistance develops from obesity and decreased physical activity in people who may be genetically predisposed. Obesity is a common finding in many, but not all of the patients with diabetes type 2. Usually, diabetes type 2 develops in adulthood, although within childhood obesity on the rise, some children are being diagnosed with this form of diabetes. Older names for diabetes type 2 are non-insulin dependent diabetes mellitus, also known as NIDDM, and adult onset diabetes. About 90% of people with diabetes type 2, because the pancreas still makes some insulin, their symptoms slowly progress, and many are not even aware that they have the disease, along with long-term complications begin. Although far fewer people have diabetes type 1, it is usually diagnosed more rapidly or quickly because the initial symptoms are sudden and severe. It is important to remember that whether a person has diabetes type 1 or type 2, the long-term complications are the same and often shorter in the lifespan. When accu-checks are done, the capillary accu-checks are measured with the capillary blood from the lateral aspects of the fingers, not to cause increased harm to neuropathic endings in the distal fingers. Some early signs of hyperglycemia: frequent urination, polyuria, increased thirst, polydipsia, increased hunger, polyphagia, blurred vision, fatigue, headache. The late signs of hyperglycemia: fruity smelling breath, abnormal pain, nausea and vomiting, shortness of breath, weakness, confusion, coma. With type 1 diabetes, the beta cells of the pancreas are destroyed and no longer produce any insulin. Insulin is necessary for life, so drug therapy for type 1 diabetes requires insulin. For patients that are diabetics type 1, they will frequently have an insulin pump, and inside this insulin pump there will be either rapid or fast-acting insulin, and this insulin will be programmed to be delivered, to be administered by the carbohydrates that they eat with each meal, or on a scheduled basis, however it is that the patient has needs for their diabetes to be cared for. If a patient is a type 2 diabetic and gets a sliding scale insulin, they will also program this pump to deliver their insulin in the same fashion. And again, in an insulin pump, it is either rapid or fast-acting insulin that is placed in these pumps. An example of your short-acting insulin is Humulin R, and your rapid-acting insulin is your Humalog, also known as your Lispro. And remember that your logs fall rapidly. That is your Lispro. It is a Humalog. Type 2 diabetic risk factors. The things that you can't fix is your age. If you have close relatives that give you the genetic factor, if you have other medical conditions that predispose you, if you have high-risk ethnic background, if you have gestational diabetes. Factors that you can improve: your weight. If you have decreased activity level, you can actually increase your activity. If you have elevated cholesterol, you can actually change your dietary intake, increase your activity, decrease your weight, and that could potentially change your prediction of diabetes. And the same thing with high blood pressure. If you change your weight, increase your activity, you could also decrease your blood pressure, and that could also decrease your risk of diabetes as well. Patients with type 2 diabetes usually have a pancreas that functions a little and can be stimulated by drugs to produce more insulin. Although insulin may be necessary for some patients with type 2 diabetes, diet, weight reduction, and non-insulin anti-diabetic drugs are often effective in maintaining good glycemic control. Non-insulin anti-diabetic drugs are oral and injectable drugs that use a variety of mechanisms other than binding to insulin receptors to help lower blood glucose levels. At one time, some of these drugs were called oral hypoglycemic agents. Although this was not an accurate name, the goal of drug therapy for diabetes type 2 is to help keep blood glucose levels within the normal target range for each person, not to make the person hypoglycemic. People who have type 2 diabetes often continue to secrete insulin from their beta cells. The extra insulin may not be needed. Drugs for this condition often work by forcing the beta cells to release the patient's own insulin. Some examples of a anti-hyperglycemic medication would be glimepiride, known as Amaryl, glipizide, known as Glucotrol, and glyburide, known as Diabeta or Micronase. But glipizide, known as Glucotrol, is a very common drug that is administered to our patients abroad. To avoid making hypoglycemia worse, assess patients for signs or symptoms of hypoglycemia before giving these medications. The signs and symptoms of hypoglycemia include tremors, sweating, confusion, rapid heart rate, hunger, headache, nervousness, and irritability, and the inability to concentrate. If any indications are present, check the patient's blood glucose level. Do not give these medications at the same time as other drugs known to increase the hypoglycemic effect. When in doubt, consult a drug reference book or call your pharmacist about which other drugs can increase the hypoglycemic effects. Ensure that these drugs are given with a meal or give no more than 15 minutes before a meal to prevent hypoglycemic episodes. It is a good idea to wait until the patient's tray is in the room before giving this medication. If the patient is NPO or is not eating a meal for some other reason, do not give this drug. These medications that are oral anti-hyperglycemic medicines can cause hypoglycemia. So it's best if a patient is not going to eat anything to hold this medication until they do, and to give this medication when they are ready to eat, and not to give it too far in advance before their meal so that it doesn't cause hypoglycemia. Another example of an oral antihyperglycemic medication is metformin, also known as glucophage. To avoid making hypoglycemia worse, assess the patients for the signs and symptoms of hypoglycemia before giving this medication. The signs and symptoms of hypoglycemia include tremors, sweating, confusion, rapid heart rate, hunger, headache, nervousness, and inability to concentrate. If any indications are present, check the patient's blood glucose level. Do not give this medication at the same time as other drugs known to increase the hypoglycemic effect. When in doubt, consult your drug reference book or pharmacist about other drugs that increase hypoglycemic effects. Ensure that these drugs are given with a meal or no more than 15 minutes prior to a meal to prevent hypoglycemia. It is a good idea to wait until the patient's tray is in the room before giving the drug if the patient is NPO. If the patient is not eating a meal for some reason or another, do not give the drug. Tell the patient and family the following: to take these drugs with or just before meals to help prevent hypoglycemia. If the patient decides to skip a meal, to skip a dose of the drug as well. For signs and symptoms of hypoglycemia, watch for hunger, nervousness, confusion, sweating, and tremors. To consume some sugar, such as glucose tablets or gel, a half a cup of juice or regular soda, or 1 tablespoon of honey or sugar. Check with the healthcare provider or pharmacist before taking any supplements or over-the-counter drugs or other prescribed drugs, because they could interact with many of the other drugs that can change blood glucose levels. Common but expected side effects of these drugs are nausea, headache, and weight gain. Metformin, also known as glucophage, should not be given to patients with kidney disease, as it can cause kidney failure. The most common side effects of metformin are related to the gastrointestinal system. They include nausea, diarrhea, gas, also known as flatulence, and weight loss. These side effects usually decrease over time. Metformin, also known as glucophage, use is associated with the risk of lactic acidosis, an unusually high concentration of lactic acid in the body. The signs of lactic acidosis include nausea, vomiting, rapid and deep breathing, and weakness, particularly muscle weakness. When used without other anti-diabetic drugs, metformin alone does not cause hypoglycemia. Metformin, also known as glucophage, interacts with the radioactive dye, the contrast medium, used in some diagnostic tests, which can lead to kidney failure. For this reason, metformin is stopped at least 24 hours before radioactive dye is used and not started again until 48 hours after the test is completed. Assess the patient's kidney function. Metformin should not be given to patients with kidney disease because it can cause kidney failure. Assess the patient for signs of lactic acidosis and report any concerning findings to your healthcare provider. Check the patient's blood glucose levels as ordered and assess the patient for signs of hypoglycemia. Metformin is safe in pregnancy for the treatment of gestational diabetes. Make sure that the patient understands that avoid drinking alcohol while taking metformin because this can increase the chances of developing lactic acidosis. The common side effects of metformin are mostly forms of GI upset, nausea, vomiting, diarrhea, and this may occur especially when the drug is first started or the dose is increased. Metformin should be stopped at least 24 hours before any test that uses radioactive dye and not started again until 48 hours after the test has been completed. Long-term use of metformin is associated with increased homocysteine levels, a risk factor for cardiovascular disease, and vitamin B12 deficiency. Laboratory tests can be done to check homocysteine and vitamin B12 levels for preventive and treatment strategies. Patients with diabetes type 2 may take oral medication to help control their glucose. They may also be on a diet control. They also may be prescribed a sliding scale insulin with AccuChecks before meals. They may also be prescribed a maintenance insulin that may be an intermediate or long-acting, and that may be prescribed to them daily or BID. This really depends upon the severity of the patient's diabetes diagnosis, or actually their response to therapies. Sliding scale insulin. The dosage given depends on assessed blood sugar. The insulin preparations are divided into 5 categories based on how quickly they start working and the length of action: rapid acting, short acting, intermediate acting, long acting, pre-mixed insulin preparations. When a patient's blood glucose level is high, you may need to use short-acting insulin to lower it. Short-acting insulin is usually prescribed on a sliding scale basis, depending on the assessed blood glucose level. It may also be taken before meals so that it starts to work as food is being digested. If a patient is allowed nothing by mouth, also known as NPO, for a test, insulin is not given because food is not given. Giving insulin with a pen device. Wash your hands. Check the order and the drug label. Remove the cap. If the insulin contains NPH, be sure that it is evenly mixed. What this means is NPH is an intermediate insulin. It has molecules in it. It is an extended release. That's what it means by intermediate. If we vigorously shake it, because it's cloudy in appearance, it will break the molecules and that will mess up its extended release. So we want to gently roll it between our hands until the cloudy liquid is mixed together well. We'll wipe the tip of the pen where the needle will attach with alcohol swab for 30 seconds. We'll remove the protective pull tab of the needle and we'll screw it onto the pen. And then we will dial 2 units. We'll keep the cap on the needle. We will not hold the pen upward like the slide says. We will hold it down. And we will press to prime those 2 units, looking for the fluid to fill the cap. And then we will dial the dose. And when we dial the dose, we then will go to the patient and administer this dose. We'll hold the pen perpendicular to and press up against the injection site with your thumb on the dosing knob. We'll press the dosing knob slowly all the way to dispense the dose, and we'll hold the pen in place for about 6 to 10 seconds. Then we'll withdraw it from the patient's skin. We will replace the outer needle cap, unscrew until the needle is removed, and dispose of the needle in a large plastic or metal container. We will not recap. There's a safety device on that needle that they have now so that when we pull it away from the patient's skin, that safety device is going to be in place so that when we go to unscrew that needle, we are not going to be exposed to that needle. Now, if we're in home health, we may not have that safety device present. And if that's the case, we're going to need to put the cap over that used needle. So in facilities, we don't recap used needles. But if we're in home health, I recommend that you recap a used needle before you remove a used needle to prevent injury. Then we will replace the cap onto that insulin pen. When insulin binds to insulin receptors on cells, the cell membranes become more open to glucose, and glucose transport proteins in the cell membranes become more active. The overall result is movement of glucose into the cells, which lowers blood glucose levels. This helps glucose to move the blood into the cells. Lispro is a rapid-acting insulin, also known as Humalog. It has an onset in 15 minutes. It peaks in 0.5 to 1.5 hours. It lasts for as long as 5 hours. Insulin aspart, also known as Novolog, is also a rapid-acting insulin. It has an onset of 15 minutes. It peaks within 1 to 3 hours, and it lasts for 3 to 4 hours. Humulin R is short-acting. It has an onset of within a half an hour. It peaks within 2 to 4 hours. It lasts 5 to 7 hours. Humulin N is intermediate, and so is NPH. So both of the N insulins, Humulin N and NPH, are intermediate, which means that they are extended release. They both have an onset of 1.5 hours. They both peak within 4 to 12 hours. They both last or have a duration 16 to 24 hours. Your NPH is a little bit cloudy. Your Humulin N is slightly cloudy too. Your Levemir, also known as Detamir, is long-acting. It has an onset of 1 hour. It peaks within 6 to 8 hours. And it has a duration of 24. Lantus, Bisaglar, Glargine. It's also long-acting. So Levemir and Lantus start with L. They're both long-acting. Lantus has an onset of 2 to 4 hours. Lantus is the only insulin that does not have a peak. But Lantus is just like Levemir. It lasts for 24 hours. Humulin 7030 is a premixed insulin. It has 70 units of Humulin N and 30 units of Humulin R. So it's a little bit of intermediate and a little bit of short-acting put together. So this is also a clear to cloudy type of insulin. You need to roll it between your hands. It has an onset of within 15 minutes. It says 0.25 minutes on your chart, but it's 15 minutes. It peaks within 1 to 2 hours, and it lasts for 24. It's not commonly used. I placed this chart in here for you to kind of get a look to see exactly what these onset, peak, and duration times look like. So if you could imagine giving your patient an injection in the morning at that 0 mark, and working your 8-hour, 10-hour, 12-hour shift. Maybe it would be a snow day and you would need to stay there the whole day and be there for 24 hours. What this would look like and what your patient would present to you while they have their insulin responding. Just something to think about and look at. There is priority of patient teaching to make sure the patient understands when to administer their insulin, to know how the insulin reacts in the body, the onset, the peak, the duration. The patient needs to understand what the signs and symptoms of hypoglycemia is and the treatment. The evaluation of what the blood glucose and the hemoglobin A1C and within or close to normal glucose parameters that the patient is needing to be in without causing hypoglycemia. It's extremely important that the patient understands what the side effects are of hypoglycemia. Select an injection site and cleanse the site with alcohol for 30 seconds. Grasp a skin fold with your non-dominant hand. Insert the needle at a 90-degree angle and inject the insulin without aspirating. Withdraw the needle and place mild pressure on the injection site without massaging it. Each diabetic patient who needs insulin is prescribed an insulin regimen, which is scheduled of insulin doses aimed at preventing hyperglycemia. The dose of insulin and how often it should be given varies among patients. Typically, patients take a long-acting insulin in the morning and a short-acting insulin to cover meals and snacks. Whenever short-acting insulin is given before a meal, the patient needs to eat the meal within 15 minutes of receiving the injection to prevent hypoglycemia. The insulin regimen is determined by the patient's blood glucose levels, age, activity level, and eating habits. Some insulin regimens require the patient to self-inject 2 types of insulin once daily. Patients need to be taught how to perform home glucose testing and maintain a written or electronic record of these test results. The information along with hemoglobin A1C testing is used by the healthcare provider to adjust the insulin regimen. Patients with DM type 2 may require insulin because type 2 diabetes tends to worsen over time, and the pancreas no longer makes enough insulin. The addition of insulin also increases the glucose-lowering effect when oral drugs alone are not adequate. Insulin may also be used for patients with DM type 2 who have allergies to the oral drugs, have liver or renal dysfunction, or are pregnant or contemplating pregnancy. Ideally choosing to inject subcutaneously at a 45-degree angle in the subcutaneous fat. The areas to choose the injection sites are the lateral aspects of the thighs, the lower aspect of the abdomen, 2 inches away from the umbilicus, because 2 inches around the umbilicus is very vascular. The posterior aspect of the deltoids and the posterior part of the upper gluteal area. Rotating injection sites is extremely important to prevent scar tissue from the injections. When we teach our patients to self-inject, we teach them to inject at a 45-degree angle, and we teach them to inject their abdomen. Steady glucose levels delay or minimize complications of diabetes, such as neuropathy and kidney damage and cardiovascular disease. Rotate insulin injection sites on the patient's body. This is necessary for several reasons. If a site is used too frequently, the body may develop scar tissue that thickens, preventing insulin absorption. Abscesses may form, and most important, rotating sites allows insulin to be evenly absorbed and thereby helps to maintain steady glucose levels and delay or minimize the complications of diabetes, such as neuropathy, eye, kidney damage, and cardiovascular disease. If the patient is self-injecting, you may need to help the patient develop a chart of site rotations, such as that shown in the figure that you see. A good rule of thumb to teach patients is that each site should only be used once a month, and each injection site should be 1 inch from other sites. A guide for a patient or even a nurse for self-injection of insulin: washing hands, inspect the insulin container for any type of insulin, checking the expiration date. Anything more than 30 days old is no longer valid to keep or to use. For rapid-acting insulin or short-acting, the insulin glargine or insulin detamere, inspect the bottle for color and clarity. If particles are present or if the insulin is cloudy, discard the bottle and open a new one. For other insulins, gently rotate the bottle or container between the palms of the hands to mix the insulin. Clean the bottle or stopper with an alcohol sponge. Leave out this step if you are using a pre-filled pen or cartridge. Remove the cover from the needle and pull back the plunger to draw the same amount of air into the syringe as the amount of insulin you will be drawing from the bottle. Push the needle through the rubber stopper and inject the air into the insulin bottle with the bottle in the upright position. Do not let the air bubble into the insulin. With the needle still in the bottle stopper, turn the bottle upside down and withdraw the same amount of insulin from the bottle as the air that you put into the bottle. Make sure that the tip of the plunger is on the line of the syringe of your insulin dose. If air bubbles are present, tap the syringe while holding it upside down, letting the bubbles come to the top of the syringe where the needle is attached. Here's a little secret. Instead of tapping, I find that if you pull back more insulin than you need, and then you push the plunger up until you push the insulin back into the bottle until you get your desired dose, you will get rid of your extra bubbles and you won't have to tap your syringe to get bubbles out. So drop the air in your syringe, put it into your stopper after you've cleansed with alcohol, that stopper. Pull back a large amount of insulin, more than your dose, more than the air that you put into that bottle, and then push back that extra amount of insulin that you've drawn up until you get that plunger to hit that dose that you need on that syringe. And you're going to find that you won't have any air in your syringe. Then you will remove the needle from the stopper and recap the needle until you are ready to inject the insulin. You select an area with your usual injection site that has not been injected within the past 2 weeks. What that means is even if the patient had the right side injected 2 days ago, it just means not the exact same spot, just slightly over from that exact same injection spot. You'll cleanse the skin area with alcohol. It's always for 30 seconds that you've got to cleanse everything. The top of a stopper, the skin site, it's got to be 30 seconds. Remove the cap from the needle on the insulin syringe. Pinch a fold of skin in the area that you cleaned and push the needle in at a 45-degree angle. Always remember 45-degree angle. If your patient has a large BMI, then it's okay always to think about doing a 90-degree angle. But not all of our patients have large BMIs. Therefore, we can't always think about doing a 90-degree injection. So always think about a 45-degree injection for subcutaneous. I know the book says 90, but it's 45 degree. If you walk into the room and your patient has a large BMI, that's a bonus. You can do 90 degrees at that point. Push the plunger all the way down to ensure the entire insulin dose has been injected. Release the fold of skin and remove the needle. Straight out quickly. Do not rub or massage the spot where you injected the insulin. Place the syringe with the needle without recapping it into a puncture-proof container called a biohazard container. There should be a safety that you should be able to slide over your needle as soon as you pull it out of the patient. Steady glucose levels delay or minimize complications of diabetes such as neuropathy and kidney damage and cardiovascular disease. Rotate insulin injection sites on the patient's body. This is necessary for several reasons. If a site is used too frequently, the body may develop scar tissue that thickens, preventing insulin absorption. Abscesses may form, and most important, rotating sites allows insulin to be evenly absorbed and thereby helps to maintain steady glucose levels and delay or minimize the complications of diabetes such as neuropathy, eye, kidney damage, and cardiovascular disease. If the patient is self-injecting, you may need to help the patient develop a chart of site rotations such as that shown in the figure that you see. A good rule of thumb to teach patients is that each site should only be used once a month, and each injection site should be 1 inch from other sites. Make sure to document the injection sites and rotation of sites to prevent lipodystrophy. Make sure the patient has a meal ready to eat before giving insulin, and check the patient at hourly intervals for signs and symptoms of hypoglycemia. Tell the patient and family that patient needs to understand what the signs and symptoms of the hypo and hyperglycemia and the appropriate interventions or actions to take for each of these. Make sure that the patient seeks emergency treatment for symptoms of ketone acidosis, which include nausea, vomiting, and changes in level of consciousness. The patient needs to take the correct procedures for testing blood glucose levels at home and how to maintain a chart of the results. The patient needs to understand the correct procedures to store, draw up, and inject insulin, rotating the injection sites, and the care and use of the insulin pump. Use a return demonstration to ensure the effectiveness of the teaching plan. An insulin vial in use may be stored in the refrigerator or for 1 month at room temperature. Insulin should be warmed to room temperature for use because injection of cold insulin may irritate the tissues. Checking the expiration date of the insulin vial to ensure the insulin is not out of date, and gently roll the insulin vial before drawing up insulin. Vigorous shaking may result in air bubbles and break down the protein molecules within the insulin. Avoid drinking alcohol because it can intensify hypoglycemia produced by insulin, causing blood glucose levels to fall too low. Insulin requirements increase when you are under stress or ill with an infection. Check your blood glucose level frequently and report abnormal results to your healthcare provider. Always carry a readily available source of sugar in case symptoms of hypoglycemia develop suddenly. Insulin is a high alert drug that can cause great harm when it is given at too high or too low a dose. Is not given to a patient for whom it was prescribed or is given to someone who does not have diabetes. If insulin is given at too high a dose or is given to a patient without diabetes, the patient can become severely hypoglycemic with risk of death. If insulin is given at too low a dose, the patient's blood glucose level will be poorly controlled, increasing the risk of severe hyperglycemia, ketone acidosis, and death. Older patients with poor vision may benefit from pre-filled insulin syringes, cartridges, or pens to prevent dosing errors. Hypoglycemia is a serious adverse effect of some of these drugs, not the desired effect. Non-insulin anti-diabetic drugs are prescribed when diet and exercise alone are not enough for a patient with diabetes type 2 to maintain the blood glucose target range identified for him or her. These drugs are not substitute for diet and exercise for blood glucose control, but are used in addition to them. Usually one drug is started at the lowest effective dose and increased every 1 to 2 weeks until the patient reaches his or her target blood glucose level on the maximum drug dose is reached. In the first drug dose, not adequately controlled blood glucose levels, a second non-insulin antidiabetic drug that works differently may be added to the first or used alone. Insulin therapy is used only when blood glucose target ranges cannot be met with the use of 2 or 3 different types of non-insulin antidiabetic agent drugs. Hypoglycemia is identified as a value of a number that registers on a glucometer or on a lab value sheet from a venous or arterial blood that is 70 or less. Patients may exhibit the signs and symptoms of sweating, blurred vision, irritability, tremors or shakiness, dizziness, rapid heart rate, headache, anxiety, hunger, weakness, or fatigue. Hypoglycemia is also the number one adverse side effect of insulin. Hypoglycemia is caused by too little glucose in the blood and can lead to death. If the patient has low glucose energy to fuel the cells is insufficient, signs and symptoms of hypoglycemia are restlessness, shaky hands, lethargic, seizures, coma. Hypoglycemia is normally treated with a small dose of glucose, such as hard candy, but patients may also choose to carry glucose preparations such as Instaglucose gel or BD glucose chewable tablets that they can take by mouth at the first sign of hypoglycemia. If patients cannot tolerate anything by mouth or are unconscious, they may be given injections such as glucagon, known as glucogen. However, intramuscular injections, and this is how the glucagon is given, is by IM, takes 10 minutes to absorb, to start acting. 10 minutes. If you're able to give something sublingually by mouth, the gel, because it can start to absorb sublingually, that will start to work within just a matter of 1 to 3 minutes. But if your patient cannot follow instructions without aspirating anything in their mouth, then that is a problem. Too risky to put something into their mouth. After a patient's blood sugar is brought up, you want to follow it with about 15 to 17 grams of protein and carbohydrates in order to get that blood sugar to not only rise, but to level out and to be maintained. Remember, if they are having a hypoglycemic episode, it's because that they have either medication or insulin that is causing that blood sugar to drop, and it's going to drop again So you need to have food in their body in order to keep that blood sugar to rise and to maintain that rise.